Hello and welcome everyone. Today we are learning about melanoma. Melanoma is a type of skin cancer. In early stages, it is cured by surgical excision, but once metastasis occurs, it is very hard to cure. Let's see how melanocytes function. The melanocytes sit at the basal level of epidermis, which promotes the UV absorbing pigment melanin. In response to UV radiation, keratinocytes produce alpha melanocyte stimulating hormone, which binds to melanocortin 1 receptor on melanocyte that signals to induce melanin synthesis. The melanocytes then transfer the melanin to surrounding keratinocytes through finger-like projections that reach out into surrounding cells. Sun-exposed keratinocytes accumulate melanin, which shields their nuclei from mutagenic effects of UV radiation. There are two forms of melanin produced by melanocyte. First is black-brown pigment eumelanin and a red-yellow pigment pheomelanin. The ratio of eumelanin to pheomelanin in the skin determines the skin color rather than number of melanocytes. The darker eumelanin is a better UV shield, and consequently people with a darker skin have a lower skin cancer risk. Pheomelanin not only offers a less protection against UV radiation, but the production of pheomelanin produces carcinogens. Pheomelanin has been shown to produce more ultraviolet A induced reactive oxidation species, leading to greater DNA damage in response to UV radiation. It has long been known that melanoma risk was tied to skin, hair, and eye coloration. People have light skin that does not tan, blonde or red hair, and light eyes have a much higher risk of having melanoma compared to population as a whole. Let's understand what is melanoma. Melanoma is a malignant tumor arising from melanocyte. 5 to 12% of melanoma are hereditary in nature. CDKN2A is a mutation commonly found in familial melanoma syndromes. Mutations in nucleotide excision repair NER pathways. They are more virulent group of germline mutations. UV radiation creates bulky DNA lesions that must be removed and repaired by repair mechanisms such as NER. And if these pathways are disrupted, the mutation events will be propagated. The driving mutations in melanoma tend to be in the signaling pathways that regulate the proliferations like BRAF, NRAS, and NF1. Growth and metabolism like PTEN and KIT. Resistance to apoptosis such as TP53. Replication lifespan TERT. Cell identity ARID2 and cell cycle control CDKN2A. Other important factors are personal characteristics such as blue eyes, fair and red hair, pale complexion, history of sunburns, freckled skin, history of benign or dysplastic melanocytic navy with number of lesions showing stronger correlation than size and immunocompromised state. Lifetime sun exposure. High UVB and UVA radiation exposures lead to melanoma. Atypical mole syndrome, formerly termed BK mole syndrome, dysplastic nevus syndrome or familial atypical multiple mole syndrome. And lastly, socio-economic status. Lower socio-economic status may be linked to more advanced disease at a time of detection, simply due to unawareness about the lesion. Now let's learn the diagnosis. In 1960, the prominent dermatologist Wallace Clark suggested that melanoma should be classified based on histological features. He initially described three histological variants of melanoma. First is superficial spreading melanoma. Second is lentigo maligna melanoma and third is nodular melanoma. While several new variants such as acral, lentigious melanoma, mucosal melanoma, desmoplastic melanoma, and nevoid melanoma have been described later. This was important work as a melanoma was once thought of homogeneous disease. Clark was first to recognize that it is actually heterogeneous disease, to show that the variants behave differently and had a differences in prognosis, and that not all melanoma should be treated in the same way. In 1966, Clark proposed a system for evaluating melanoma based on the depth of invasion of melanoma cells into dermis and subcutaneous fat. Level 1 is melanoma cells are confined to epidermis, which is called melanoma in situ. Level 2, invasion of single cells or very small nest of melanoma into papillary dermis. Level 3, melanoma cells fill and expand the papillary dermis. Level 4, invasion into reticular dermis. Level 5, invasion into subcutaneous fat. In 1970, Alexander Breslow independently devised a more accurate method for classifying melanoma based on a measured depth of invasion that captured the thickness of tumor. Breslow's classification system, known as Breslow's depth, was based on depth of invasion in millimeters rather than the depth by anatomic compartments. Stage 1 is depth less than or equal to 0.75 millimeter. Stage 2, 0.76 to 1.5 mm. Stage 3, 1.51 to 2.25 mm. Stage 4, 2.26 to 3 mm. Stage 5, greater than 3 mm. Patients with thinner melanomas had a much better chance of survival and a lower risk of regional and distant metastasis. Imaging technologies have been developed for the use by technicians as an adjuvant to visual screening alone. These devices aim to help clinicians decide whether the biopsies are needed for ambiguous lesions. Two devices, Malafine and SIA scope, are used to visualize lesions and give information to help clinicians decide whether a biopsy is necessary. They use visible and near infrared light. Regardless to detection of method, diagnosis of melanoma requires that a lesion to be recognized as a clinically atypical and it must be biopsied. In the histopathology, the main modalities are H&E staining and IHC staining. For melanoma, there are two types of biomarker most commonly used for diagnostic and prognostic purposes. First is melanocytic marker and second is proliferative marker. Melanocytic markers are used to determine if an ambiguous lesion is melanocytic in origin and tend to be proteins involved in melanin synthesis, melanosome biogenesis, or melanocyte differentiation, while proliferation markers are used to evaluate cell cycle activity in a lesion. Currently, the determination of tumor proliferation is typically done counting mitotic figures. Melanocytic markers are HMB45, Melan A or MART1, S100 protein, microophthalmia transcription factor MITF, tyrosinase and SOX10. Melan A and HMB45 have highest specificity. Prognostic markers. The most commonly used proliferation marker is Ki67. A protein involved in ribosomal transcription, the expression of which is associated with cell proliferation and is highly elevated in most aggressive melanomas. Other marker is phosphohistone H3. Serum marker. One of the strongest independent prognostic factor for melanoma is lactate dehydrogenase. Treatment. First is surgical removal. Surgical removal of tumor and surrounding healthy tissue is a primary treatment for localized melanoma, and sentinel lymph node biopsy is preferred in patients whose tumors are greater than 0.8 mm thick or are thinner but are ulcerated. If melanoma cells are found in sentinel lymph nodes, then the remaining lymph node in the surrounding areas are also removed. Chemotherapy. For patients with metastatic disease, surgical treatment alone will not be curative, and drug therapies are the next line of defense. Dacarbazine is a chemotherapeutic agent that helps in melanoma. Targeted therapy. Multiple targeted therapies have been developed to combat molecular defects present in melanoma. The most promising of these include BRAF inhibitors, vemurafenib and dabrafenib, that were approved for treatment of metastatic and unresectable BRAF mutated melanomas. Immunotherapies. Tumor antigens are classed into two groups: tumor associated antigens, which are mostly found in tumor cells though are expressed in the normal cells as well, and second is tumor specific antigens, which are solely expressed in the tumor cells. Melanoma tumors have a group of antigens specific to melanoma cells. These antigens are involved in melanoma differentiation and are called melanoma differentiation antigens, MDA. These TAA, TSA and MDA are all proteins that are displayed on MHC class I proteins on melanoma cell surfaces, which can alert the immune system that cells are diseased. The antigen displayed on MHC class I proteins are recognized by the T cell receptors found on CD8 positive cytotoxic T lymphocyte, which can kill the cells that are non-self or disease self cells. These lymphocytes, when histologically visualized in the microscope in the evaluation of tumor, they are called tumor infiltrating lymphocyte. The number of TILs present in the tumor is a prognostic indicator in some tumor, including melanomas. If there are no TILs present in the tumor, this is the sign that tumor has successfully evaded immune system and correlates with worse prognosis. After understanding this dynamic of immune reaction, there are three main types of immune treatment for cancer. First is cancer vaccine, second is adaptive cell therapies, and third is immunomodulatory strategies. So first is interleukin 2. It is pro-proliferative cytokine which promotes the expansion of melanoma specific T cells, but it is highly toxic. Second is immune checkpoint inhibitors. On the surface of T cells, there is a protein called programmed cell death protein 1, PD1. PD-L1/2 is commonly overexpressed in the cancer including melanoma, enabling tumor cells to effectively turn off the immune response and evade the immune destruction. Treatment with antibodies to PD1, PD-L1/2 and CTLA4 effectively block binding to the respective ligands and corresponding signal that causes tolerance, allowing for stimulation of an immune response. These drugs are anti-CTLA4 antibody ipilimumab and two anti-PD1 antibodies nivolumab and pembrolizumab. The treatment of metastatic melanoma has greatly improved in the recent year with the introduction of treatment such as BRAF, CTLA4 and PD1 inhibitors. We will discuss the gross and microscopy of melanoma in detail in upcoming video. So these are the references for this video. Hope you like it. Thank you. See you in the next video. Bye.